I've spent years inside operating rooms, opening chests and working directly on the human heart. I've seen what a strong, healthy heart feels like, and I've also felt the difference when that same heart is slowly failing without making much noise. And here's what most people don't realize. Some of the most serious damage I've witnessed wasn't caused by bad eating habits. It wasn't smoking, and it wasn't something people were born with. It came from something far more subtle, something most people trust without question: medication. Drugs prescribed correctly, given with good intentions, approved, studied, and still, in certain situations, quietly placing stress on the heart over time. My name is Dr. Jason Watanabe. I'm a cardiac surgeon, and I've operated on more than 1,200 patients throughout my career. Today I use this channel to share what I've learned, so you can protect your heart before it reaches the point where surgery becomes the only option. In this video, I'm going to walk you through 5 types of medications that millions of people over the age of 60 take every single day. And yet, in most short medical appointments, the full impact of these drugs is rarely discussed. This isn't about fear, it's about awareness. Because once you understand what's happening inside your body, you can start asking better questions and making better decisions alongside your doctor. As we age, the way the body handles medication changes. Your kidneys don't filter as efficiently as they once did. Your liver slows down when processing substances, and that means drugs can stay in your system longer and interact in ways that weren't originally expected. Now think about this. Most people over 65 are taking multiple prescriptions at the same time. 4, 5, sometimes even more. Each of those medications was tested on its own, approved on its own. But what happens when several of them are combined inside a body that's already under more strain than it used to be? That's where things start to get complicated. And unfortunately, that complexity doesn't always get the attention it deserves during a routine consultation. Let me tell you about someone I'll call Clarence. He was 74 years old, a retired electrician. The kind of person who did everything right, stayed active, paid attention to his diet, kept a disciplined routine. On the surface, he had every reason to believe his health was under control. But something didn't feel right. He wasn't just tired. It was a deep, persistent exhaustion that didn't go away, no matter how much he rested. He started waking up in the middle of the night with muscle cramps. His thinking felt slower, less sharp, and that began to worry him. He went from doctor to doctor, and every time he heard the same thing: "You're 74. This is normal." He lived like that for 2 years. Then, after his second cardiac event in less than 18 months, he finally came to see me. I sat down and reviewed everything, every prescription, every dosage, every detail, and within minutes, the issue became clear. It wasn't just one problem. There were 3, happening at the same time, all connected to his medications, all overlooked, for 2 full years. And the way this story ends is exactly why you need to stay with me until the end of this video. Let's talk about the first one: statins. If you're over 65, there's a very real chance you're taking one right now. The names may vary: atorvastatin, rosuvastatin, simvastatin. But the way they work is essentially the same. And I want to be very clear about something. Statins have saved lives. In patients with established cardiovascular disease, the data supporting their use is strong. I've prescribed them many times myself, and I still do when they're appropriate. But there's a detail most people are never told. Statins interfere with a pathway in the body known as the mevalonate pathway. And that pathway doesn't just produce cholesterol. It also produces something called coenzyme Q10, CoQ10, and that's where things start to change. CoQ10 plays a critical role in how your heart generates energy. Your heart is constantly working every second of your life, and it depends heavily on this compound to function efficiently. Without enough of it, the system doesn't stop immediately, but it begins to struggle. Think of it like running an engine without proper lubrication. It still runs, but not smoothly, and not for long. Multiple studies have shown that statins can significantly reduce CoQ10 levels in the bloodstream, often by 30 to 50%. Now imagine that happening in the one organ that depends on energy the most. In real patients, what we often see is this: persistent fatigue that doesn't improve with rest, muscle weakness, mental fog, and in some cases, even a measurable decline in heart performance. Clarence had been taking a high-dose statin for 2 years. 2 years with his heart functioning below its full potential, without anyone connecting the dots. And here's something that deserves your attention. Testing CoQ10 levels is not routine. It's not part of standard guidelines. In many cases, it's not even covered by insurance. And since CoQ10 is available over the counter, there's very little incentive within the system to bring it into the conversation. This isn't about pointing fingers. It's about recognizing that some questions simply aren't being asked. Now, in certain cases, supplementing with CoQ10, typically in the range of 100 to 200 milligrams per day, has been associated with improvements, particularly in patients with compromised heart function. But the key here is not self-prescribing. The real question you should be asking is this: should I be taking CoQ10 alongside my statin? Write that down. Bring it to your next appointment. Not, should I stop my medication? Just that question. Now let's move to the second category, and this one surprises almost everyone, because it doesn't look like a heart-related drug at all. Ibuprofen, naproxen, diclofenac. These are non-steroidal anti-inflammatory drugs, NSAIDs. They're everywhere. Easy to access, inexpensive, and often seen as harmless. Most people assume they reduce inflammation, and since inflammation is linked to heart problems, they must be neutral or even beneficial. But that assumption is misleading. These medications act by blocking enzymes known as COX enzymes, and one of those, COX-2, is responsible for producing a substance that helps protect your blood vessels. When that protective mechanism is reduced, the balance inside your cardiovascular system begins to shift. And that shift is where the risk begins. When you block that protective pathway, your blood vessels lose part of what keeps them flexible and stable. At the same time, something else begins to happen in the background. Regular use of NSAIDs, those common anti-inflammatory pills, has been shown to increase blood pressure, on average by about 3 to 5 points. Now that might not sound like much, but after the age of 60, your arteries are already less elastic than they used to be. That small increase, sustained over time, quietly adds up. Year after year, it raises the likelihood of serious events like stroke and heart attack. This isn't speculation. In 2015, the FDA required a black box warning on these medications, not just for stomach issues, but specifically for cardiovascular risk. That warning is still there today. Clarence had been taking ibuprofen every single day for 2 years. His physician was aware, but no one stepped back to evaluate what that meant for his heart over time. And this is where nuance matters, because the goal is not to eliminate treatment. It's to use it more intelligently. For chronic joint pain, there are alternatives that may reduce systemic exposure. Topical anti-inflammatory gels, for example, act locally and significantly limit how much of the drug circulates through your entire body. For ongoing low-grade inflammation, certain nutritional strategies have shown promising data. Compounds like curcumin, when combined with absorption enhancers, and omega-3 fatty acids, particularly EPA and DHA, have been associated with measurable cardiovascular benefits. But let me be very clear. This is not about replacing prescribed medication on your own. It's about asking better questions, understanding the trade-offs, and working with your doctor to find the safest long-term approach. Now the third category. This one stayed under the radar for far too long, because it doesn't look like it has anything to do with the heart. In fact, many people take it daily without a second thought. Proton pump inhibitors. Medications like omeprazole, pantoprazole, lansoprazole. They're commonly used for acid reflux. Some people take them for years, even decades. And here's the part most people never hear. Stomach acid is not just something your body produces by accident. It serves a purpose. One of its key roles is helping your body absorb vitamin B12. When acid production is suppressed over long periods, that absorption process is significantly impaired. And that matters more than most people realize. Vitamin B12 plays a critical role in regulating a compound called homocysteine. When homocysteine levels rise, they begin to damage the inner lining of your blood vessels. Elevated levels have been linked to an increased risk of cardiovascular events, independent of cholesterol. And yet, this is rarely part of routine discussions. Studies have shown that long-term users of proton pump inhibitors tend to have significantly lower B12 levels compared to those who don't take them. Now combine that with aging. After 60, your body already becomes less efficient at absorbing B12 naturally. So you're dealing with two layers of reduced absorption, one from age, one from medication. And the symptoms don't always appear dramatically. It can start as fatigue, subtle memory issues, a tingling sensation in the hands or feet that slowly becomes more noticeable over time. In more advanced cases, the damage can become permanent, and it all began with something as simple as a pill for heartburn. But it doesn't stop there. These medications can also lower magnesium levels, and magnesium is essential for your heart's electrical stability. It helps regulate the signals that keep your heartbeat consistent and controlled. When levels drop, the risk of irregular rhythms increases. Muscle cramps become more frequent, and those early morning wake-ups, like the ones Clarence was experiencing, start to make more sense. When I reviewed his labs, his B12 levels were critically low. His magnesium was technically still within the normal range, but right at the bottom. Close enough to be flagged, but not enough for anyone to act on it. And that's often where problems hide. If you've been using a proton pump inhibitor for a long period of time, there are two simple questions you should consider bringing to your next appointment. Should we check my B12 levels? And what about my magnesium? Because sometimes the issue isn't what you're taking. It's what your body can no longer absorb because of it. Let's continue. For patients who are already dealing with low B12 levels, there's a form that bypasses the usual absorption problem entirely: methylcobalamin. Taken sublingually, under the tongue, it doesn't depend on stomach acid. It goes directly into the bloodstream, avoiding the very mechanism that long-term acid suppression interferes with. Magnesium can also be addressed, but the form matters. Magnesium oxide, which is commonly found in cheaper supplements, is poorly absorbed. Forms like magnesium glycinate or citrate tend to be more bioavailable, often in the range of 200 to 400 milligrams daily, depending on the individual. But there's something extremely important here. If you've been taking a proton pump inhibitor for a long time, stopping it abruptly can actually make things worse. There's what we call a rebound effect. Acid production comes back stronger than before, symptoms flare up, and many people end up going right back on the medication, sometimes indefinitely. That's why any adjustment needs to be gradual, controlled, supervised. Now step back for a moment and look at the bigger picture. A statin potentially lowering CoQ10, an NSAID reducing vascular protection while raising blood pressure, a PPI interfering with B12 and magnesium. All of this happening at the same time. That was Clarence's situation. For 2 years, his body was trying to compensate for multiple overlapping effects. Each medication made sense on its own. Each prescription was justified individually. But no one stopped to ask what the combination was doing over time. Each specialist focused on their area. No one connected the full picture. Now the next 2 medications are where things become even more uncomfortable. Because for years, many of us in medicine, myself included, didn't fully appreciate the long-term consequences. The 4th one involves a drug that prevents dangerous blood clots, while quietly contributing to a process I've seen firsthand during surgery. And the 5th? That one forced me to rethink advice I had been giving to patients for over a decade. I'll tell you exactly what changed, and what I had to start saying differently. But stay with me, because what comes next may challenge what you've always believed was standard and safe. Let's talk about number 4, warfarin. It's been around since the 1950s and remains widely prescribed, especially in patients over 65. It's used in conditions like atrial fibrillation, deep vein thrombosis, and in those with mechanical heart valves. And again, I want to be clear, warfarin works. It reduces the risk of clot formation. It lowers the chance of stroke in high-risk patients. It has saved countless lives. But there's a layer to this that rarely gets explained in a short consultation. Warfarin works by blocking vitamin K. But vitamin K isn't just one thing. There are different forms, and one of them, vitamin K2, plays a very specific and critical role in the body. It activates proteins that help keep calcium where it belongs, in your bones and out of your arteries. When that system is disrupted, calcium can begin to deposit along the walls of blood vessels. Slowly, silently. Over time, those vessels become more rigid, less flexible, almost like pipes that are gradually filling with mineral buildup. And here's the key point. Warfarin does not distinguish between the different forms of vitamin K. So while it's doing its job, preventing clots, it may also be interfering with the body's natural defense against vascular calcification. Research has shown that long-term use of warfarin is associated with increased calcification in coronary arteries when compared to certain newer anticoagulants. And from a surgical perspective, I can tell you this. Heavily calcified arteries are more difficult to work with. They're less forgiving. They complicate procedures, and they can impact long-term outcomes. So the question becomes, does this mean patients on warfarin should stop taking it? Absolutely not. And that's exactly where the conversation needs to become more precise. Absolutely not. Leaving atrial fibrillation untreated carries a serious risk, around a 5% chance of stroke each year. That's not something anyone should take lightly. But what it does mean is that the conversation needs to go deeper. There are two important questions you should consider bringing to your next appointment. First, with the newer anticoagulant options available today, is warfarin still the best choice for me? Medications like apixaban or rivaroxaban work differently. They don't interfere with vitamin K in the same way, which may change the long-term impact on your arteries. Second, has anyone ever checked my coronary artery calcium score? This is a simple CT scan, low in radiation, that gives a direct look at how much calcification is already present inside your arteries. It's one of the most underused tools in cardiology, because instead of guessing risk, it shows you exactly what's happening. And that kind of information can completely change how treatment decisions are made. Now, the fifth and final one. This is the hardest for me to talk about, not because it's complex, but because for years I recommended it myself, confidently, routinely, to patients who trusted me. And looking back, I was wrong. Calcium supplements. If you're a woman over 60, there's a strong chance you've been told to take calcium for bone health, usually around 1,000 to 1,200 milligrams a day. It's so common, it barely feels like medical advice anymore. It feels like common sense. But sometimes, common sense isn't the full story. Years ago, a large analysis brought together data from multiple clinical trials, thousands of patients, and found something that changed how I look at this completely. When calcium is taken in supplement form without proper balance, especially without vitamin K2 and vitamin D3, the risk of cardiovascular events increases significantly, not slightly, significantly. Now pause for a moment and picture this. A group of 100 women, all doing what they believe is the right thing, taking calcium every morning to protect their bones. And a portion of them may actually be increasing their risk of heart problems at the same time. This is what's often referred to as the calcium paradox. When calcium enters your bloodstream in large, concentrated amounts from a supplement, your body doesn't always handle it efficiently. Instead of being directed into the bones, some of it can end up depositing in places it shouldn't be, like your arteries. The same kind of calcification we talked about earlier, except this time, it's being driven not by a medication, but by something intended to help. And that's where the real issue lies. You take something to strengthen your bones, but over time, it may contribute to stiffening your blood vessels. So why hasn't this changed across the board? Because changing long-standing medical recommendations isn't simple. When guidance has been given to millions of people over decades, there are layers, clinical, institutional, even economic, that slow down how quickly new perspectives are adopted. Sometimes, instead of a clear reversal, what happens is a quiet adjustment. A note added, a nuance introduced. but not always a direct statement saying, "We need to rethink this." For the first 15 years of my career, I recommended calcium supplements to older patients, especially women. It was automatic, standard practice. And at the time, I believed I was helping. But medicine evolves. And sometimes that means facing uncomfortable truths and changing what we once thought was right. Let me tell you something personal. For years, I followed the exact guidance I was trained to give. A 68-year-old woman comes in with early bone density loss, and the recommendation was almost automatic. Calcium, vitamin D, around 1,200 milligrams a day. Take it with food. I said it hundreds of times, because that's what we were taught. That was the standard. But then I came across data that forced me to stop and really think. I went back in my mind to every patient I had given that advice to. Every woman who trusted me and started that routine because I told her to. And I had to confront something important. I wasn't guilty, but I was responsible. Not for what I didn't know at the time, but for what I do with the knowledge now. And that's exactly why this conversation matters. That's why I'm making this video. Because the goal isn't to panic or to suddenly stop everything you're taking. If you've been prescribed calcium due to bone loss, you should not discontinue it abruptly, but you should ask a better question. Should I be taking vitamin K2 and vitamin D3 alongside my calcium? For many patients, the answer is yes. Vitamin K2, especially in the MK7 form, helps guide calcium into the bones where it belongs. Vitamin D3 improves absorption and plays a key role in overall balance. Typical ranges often discussed include around 100 micrograms of K2 daily and at least 2,000 IU of vitamin D3, though individual needs can vary depending on blood levels. And just as important, whenever possible, calcium should come primarily from food. Dairy products, leafy greens, small fish consumed with their bones. Supplements should fill gaps, not become the main source. Now, throughout this video, we've talked about what certain medications and supplements can unintentionally take away from your body. So let me shift the focus for a moment. What does real heart support actually look like after 60? Because the truth is, it's not overly complicated, and much of it doesn't require a prescription. Omega-3 fatty acids, particularly EPA and DHA, have been associated with improved triglyceride levels, reduced inflammation, and better vascular function. Magnesium, especially in well-absorbed forms, supports heart rhythm, blood pressure regulation, and even sleep quality. Curcumin, when properly absorbed, has shown potential in addressing chronic, low-grade inflammation, the kind that quietly contributes to cardiovascular risk over time. There are also compounds like nattokinase, which has been studied for its role in supporting healthy blood flow, and taurine, which plays a role in cardiac muscle function. Aged garlic extract has demonstrated benefits related to blood pressure and arterial flexibility. But let me be clear about something. None of these are miracle solutions, and none of them replace medication when medication is truly necessary. What they represent is support. They help restore what the body needs to function properly, especially when age, lifestyle, or medications begin to shift that balance. Now, before your next appointment, there's one simple step I want you to take. Write everything down. Every medication, every supplement, every dosage. Because when you see the full picture on paper, you start asking better questions. And better questions lead to better care. Before your next appointment, I want you to do something simple but powerful. Write down everything you take, every prescription, every supplement, every dose. And at the very top of that page, write 3 words. What am I losing? Because every medication comes with a trade-off, and you deserve to understand yours. Statins may help control cholesterol, but they can lower CoQ10. Proton pump inhibitors reduce acid, but can interfere with B12 and magnesium. Warfarin helps prevent dangerous clots, while potentially affecting how calcium behaves in your arteries. Calcium supplements may support bone health, but under certain conditions may contribute to vascular stiffness. None of this automatically means a medication is wrong for you. It means the conversation isn't complete without understanding both sides of the equation, and you deserve that full picture. Let me take you back to Clarence. After reviewing everything he was taking, I didn't rush the process. We sat down, and instead of a quick visit, we spent time, real time. We went through every medication, every interaction, every possible overlap. Then I reached out to the rest of his care team, his cardiologist, his primary physician. Together we built a plan. We introduced CoQ10 support, addressed his B12 deficiency immediately with a form his body could actually use, added magnesium in a form that could be properly absorbed, replaced daily oral anti-inflammatories with a topical alternative to reduce systemic impact, and gradually adjusted his acid-suppressing medication under supervision. Nothing extreme. No new procedures, no experimental drugs. We simply stopped removing what his body needed and started restoring balance. That's all. 6 months later, I received a call. He said, "Doctor, I feel like myself again." The exhaustion that had followed him for years, gone. The nighttime cramps disappeared within weeks. His follow-up evaluations showed clear improvement. Even his primary physician was surprised. The progress didn't match what would normally be expected. But from my perspective, it did. Because the issue was never just one thing. It was the accumulation. What still amazes me, even after all these years, is not how complicated the problem was, but how straightforward the solution became once the full picture was finally addressed. The medications we discussed today are not the enemy, and the doctors prescribing them are not careless. The real issue is something more subtle. A system that focuses on starting treatment, but doesn't always create space to reassess how everything interacts over time. You may not be able to change that system overnight, but you can change how you walk into your next appointment, with your list, with your questions, with those 3 words at the top. And sometimes, that alone is enough to change everything. If this message connected with you, consider sharing it with someone in your life, maybe a parent, a partner, or a friend who's been told that constant fatigue is just part of getting older. Because sometimes, it isn't. Everything I've shared here is based on clinical experience and published research, but your situation is unique. So don't make changes on your own. Use this as the starting point for a deeper conversation with your physician. Take care of your heart. It has been working for you every second of your life, without ever asking for a pause. The least we can do is start paying attention.